Good afternoon everyone and welcome all. I am Dr. Natasha. Today we are here to present our first academic session following the appointment of new Executive Committee of Government Medical Officers Association at 98th Annual General Meeting. Since recently we had our election after 10 years and establishing island-wide victory among our medical officers led by Dr. 𝗙𝗢𝗟𝗟𝗦𝗧𝗏, consultant neonatologist, the president of the GMO, and Dr. 𝗙𝗢𝗟𝗟𝗟𝗢𝗪 as secretary of the GMO. It's a new dawn and new era where there are so many plans and agendas to work towards the better future of our members. As the initiative step, here we are broadcasting the academic session regarding the risk of re-establishment of malaria in Sri Lanka by Dr. Indeewarie Gunaratna, consultant community physician, currently serving at the anti-malarial campaign in Sri Lanka with over 18 years of experience in public health and more than 12 years specifically in vector-borne disease programs. She brings a wealth of knowledge and practical expertise. Dr. Gunaratna has worked across all levels of public health implementation, ranging from grassroots MOH level to regional and national levels. She holds a master's degree in medical entomology and applied parasitology and has specialized in parasitology and entomology related to vector-borne diseases, other than her specialty in community medicine. Her work in molecular xenomonitoring has earned her international recognition. She has been a member of the WHO Global Strategic and Technical Advisory Group for Neglected Tropical Diseases since 2022 and also contributes to the global scheme Neglected Tropical Diseases, Epidemiology and Surveillance Working Group. Additionally, she serves on the project review group for the development of the Integrated Post-Validation Surveillance Plan in Turkey. So, Madam, over to you.
Thank you, Dr. Natasha. Today's lecture is on the risk of re-establishment of malaria in Sri Lanka. So, I'm the consultant, Dr. Indeewarie from Anti-Malaria Campaign. So, this would be a refresh your parasitological knowledge on malaria, which you learn in the faculty. So, because you don't much deal with these diseases, these are rare diseases now in Sri Lanka. So the word malaria is an Italian name, meant bad air, as initially they thought the disease is related to polluted air, as it was associated with swamps in Italy. So it is a life-threatening disease and is caused by Plasmodium species of parasites and transmitted by Anopheles species of mosquitoes. So it remained a major public health concern in many tropical and subtropical regions in the world. So there is a significant progress in reduction of the burden of the disease in the world, but still millions of people are affected in countries, especially in sub-Saharan Africa and parts of Asia, including India. So because of that, it's a major threat for us as a Sri Lankans because there is increased migration towards to these countries, especially African countries and India. So this is the distribution of cases in tropical and subtropical countries. So why these tropical and subtropical countries are at risk of all these vector-borne diseases are they have the ideal environment for vector breeding and vector distribution, and everything is ideal because they have ideal temperature, humidity, rainfall, everything suits the vector propagation, breeding and the propagation. So this is the distribution of cases in these countries, and the global eradication efforts began in mid-20s, 20th century, but face very challenges due to resistance to mosquito resistance to special insecticides and also for special drugs for malaria. And this shift towards long-term control and elimination strategies in the world. So all the vector-borne diseases goes according to this epidemiological triad. This is the epidemiological triad, and it has a disease agent. In our case, it's a parasite called Plasmodium, and it has a vector in our case it's the Anopheles mosquito, and a host, which can be either human or an animal in relation to malaria. So in these diseases, environmental factors play a major role in transmission, and this is the reason why these vector-borne diseases are, as I mentioned, prevalent in tropical countries and difficult to get rid of. So one after the other, different diseases, vector-borne diseases are either emerge or re-emerge. Now these days also you experience chikungunya. It was there and it re-emerged vector-borne disease. So we have leishmaniasis, it's an emerged disease in the country. What is it? Dengue, it is endemic now. And the chikungunya re-emerged, and malaria eliminated, and filariasis eliminated as public health problem. So one after the other, we experience different kinds of vector-borne diseases. These are the 5 parasites causing malaria in the world, where Plasmodium falciparum is the most deadliest one. And it is most prevalent in sub-Saharan Africa and cause severe malaria, including cerebral malaria and all the end organ failures. And it has a shortest incubation period, and it rapidly multiplies in the blood. So people go into anemia because of the rupture of all the blood cells with infected when the blood cells are infected. So Plasmodium vivax is more common in Asia and Latin America, and the problem with the vivax is that it can lie dormant in the liver as hypnozoites and cause relapses weeks or months after the initial infection. So we have to follow these patients up for like 1 year because they can develop these relapses. This is less fatal than falciparum malaria, but still significant in terms of illness and relapses. There are other species like Plasmodium ovale found in African countries. It's just like vivax infection, and it causes milder symptoms and it's less common. And malaria, Plasmodium malaria infection is also less common in the world, and it has a longer incubation period and cause chronic infection that persists for years. Typically these parasites cause milder symptoms, and this one, the 5th one, is Plasmodium knowlesi. It's a zoonotic species, so it is transmitted from animals, particularly from macaque monkeys, and it is found in Southeast Asia. The threat of this parasite is, now we have found the vector in the country, Anopheles stephensi, which can give the transmission, cause the transmission within the country. Now these stephensi vectors have been confined to north and east some of the districts. We have been able to control the vector. But if these parasites are introduced to the country, there will be a huge threat of transmission, and it causes severe disease in humans, and it is easily misdiagnosed as Plasmodium malariae, which is a milder form of malaria. So malaria is transmitted by female mosquitoes, Anopheline mosquitoes, and there are more than 400 species. And we have found that for about 30 to 40 are considered significant malaria vectors. And it is a night biter, not like dengue. It's a night biter and breeds in ponds, paddy fields, puddles, river margins, and rock pools, where we can see clean, slow-moving, stagnant water. So these are the notable vector species by regions. In Sri Lanka, our primary vector is Anopheles 𝗙𝗎𝗓𝗡𝗙, if you all can remember these names when you were doing parasitology lectures. This primary vector is the one who can create or initiate the outbreak when the parasite is introduced to the country. And these secondary vectors, there are several secondary vectors they can propagate the outbreak once it is initiated by Q. So we have Anopheles subictus, annularis, varuna, vagus, and tessellatus. So malaria is the disease which caused the largest epidemic in the history of Sri Lanka. So it infected 5.5 million people in 1930s when the country's population is like 5 million. So all the people have got reinfected, and there were much more cases than the actual population in the country, and it killed more than 80,000 people within 7 months. So to compare the severity of this outbreak, I will give you few examples. The 30 years war in this country killed only 70,000 people. For 30 years, those are the things that we think huge deaths occur in the country. And COVID was acquired by 670 people and killed 16,800 people. And the largest dengue epidemic, which was in 1970s, infected 186,000 population and killed only 440 patients. So you can see case fatality rate is much higher with malaria when compared to other diseases. And this is how it appeared in epidemic forms in the history, and how we control time to time. So this is the 1934 to 5. You can see sorry, I want to take the point option. Here, this is 1934 to 35. We had the largest epidemic, and there were some strategies applied during that period. We used DDT as the insecticide to control the vector, and we were able to bring down this whole epidemic to a near elimination level in 1963. But due to negligence and diversion of resources to other diseases, and given less priority to these control efforts, it re-emerged, and thereafter it took 30 years for us to bring it back to the same level of elimination. So though we eliminate these diseases, we can't just forget it. So we have to sustain elimination, and it is more challenging, and it needs more resources than you control a disease. So different strategies used in the history. So we used malathion later on in 1975. Again, resistance to malathion occurs. DDT resistance was there. Thereafter, we are using 𝗙𝗕𝗦𝗖𝗥𝗕𝗦𝗪, and we are carefully using. It's not like fogging everywhere. We just preserve these insecticides to be used in an outbreaks, because if the resistance develop for these insecticides by the mosquitoes, then we will run out of any insecticides to control outbreaks. So we use this as a targeted focal sprays based on the cases, and still we have not found any resistance to 𝗙𝗕𝗦𝗪. And also there was this combination therapies, treatments were introduced to control the parasite. Actually, this artemisinin combined therapy was very effective to for us to come back to these elimination levels. It cleared all the parasites in the country, and we had this global fund support, which supported us to procure all these long-lasting insecticide impregnated bed nets. So these are the main strategies which supported us to bring down malaria to this level of elimination. Anyway, we were able to stop the indigenous transmission in 2012. We got our last indigenous cases in 2012, and this is how the map was cleared during these years from 1999 to 2012. The map was cleared. All these strategies that I explained actually helped us to bring down this incidence to 0 level. And we had our last death in 2007. Then in 2016, WHO declared Sri Lanka as malaria free. And Plasmodium falciparum and Plasmodium vivax were the most common species in the country before elimination. We had only those 2 parasites, but now we experience all the parasites because now we only have imported cases from all over the world. So this is how the disease can be reintroduced and re-established in the country. Because my title is also the risk of re-establishment. So this is the imported case. We can't stop actually these imported cases. This can be imported through our Sri Lankans or the people, foreigners who come with the parasite to the country. So there are about 50 cases every year. We get 50 to 60 cases of imported malaria, and through the mosquitoes in the country, we have not eliminated mosquitoes, only the parasite is eliminated. So these mosquitoes can bring these parasites to our people in the local community, and when it is given to a local person, it is called an introduced case. Now this imported case has introduced the parasite into our people, and then from one local person to another local person, if the transmission occurs through a mosquito, that is called indigenous transmission. So this indigenous transmission is not there in the country because before that we do all the things to prevent spread of the disease from this imported case to the introduced case. So when these indigenous cases appears 3 consecutive years in the same place, it is called re-establishment. So I think we will not go up to that level. When we go for this re-establishment level, then the WHO will take back the certificate that they have given as eliminated to the country. So we will not allow anything like re-establishment to occur in this country, but we are still struggling to prevent this importation of malaria into the country. So since elimination in 2012, the last case was in 2012, we got the certification 2016, we got one introduced case in 2018 from Zinbalandua, from an Indian worker. It was introduced to a Sri Lankan. And one transfusion introduced case. You know, we check all the blood in the blood bank for malaria parasites, but there was a introduction of this parasite through a blood pack given to a Sri Lankan who has never traveled outside the country. So that is a transfusion induced case in 2021, and there were 2 deaths in 2023 and 2024. In this year, in 2025, so far we have 19 cases. Today morning also there was one case reported from Jaffna. So knowing epidemiology is important for us to know whom we have to suspect malaria and to identify vulnerable populations and actually people who need our service. So almost all patients were males in 2024. This is because these are economically productive people who go to malaria endemic countries for occupation. So those are all imported. So imported cases, they mainly among the males, and majority were between 20 to 50 years. Again, they are economically active population. And this is important. This is 76% of cases for Sri Lankans. So it's not the foreigners who bring malaria to this country. Mainly it's the Sri Lankans who go abroad to these endemic countries and bring back malaria to the country. So most of these cases are reported from Western province. So the doctors in Western province should be more vigilant of patients presented to you with fever and travel history. But there is a high chance of missing cases in other districts as well, because we think the incidence is very low and you will not get any cases in other districts as well. But every year we get at least one case from all the districts. And there is high chance of missing in the other districts as well, because we think the incidence is very low and we ignore asking the travel history from patients with fever. So it is not only doctors in Western province, all the doctors have to include malaria in the differential diagnosis when patients are presented to you with fever, especially with travel history or belonging to any of the risk categories. So this is an important slide. These are the risk categories which you have to think of malaria when you are taking the history in a fever patient. So these are the main risk groups for introduction of malaria to the country, and Sri Lankans who are at risk. When we take the Sri Lankans who are at risk of acquiring malaria include illegal migrants, first one, to malaria endemic countries, because we in this year now we have got 2 cases from Jaffna, one even with cerebral malaria. Those are illegal migrants who did not reveal their travel history. So it is a risk, and because of that the delay in diagnosis is high, and we all diagnose the patient once they develop severe complications. And people who involved in gem trading in African countries, especially gem traders who live in Beruwala China Fort, Ratnapura, 𝗙𝗢𝗟𝗪𝗓, Balangoda, Ginthota in Gaul, and they may travel to Mozambique, Madagascar, Uganda, Tanzania. So in your history, just try to elicit the travel history if they belong to these risk categories. And triforces and police who are going for UN peacekeeping missions to South Sudan or Central Africa are at risk. And people who involved in security services, there are sea marshals and seafarers shipping in African regions, so they are at risk. And the migrant workers involved in textile projects in Ethiopia, Ghana, and water projects and tile projects in India, and finance companies in Zambia or Myanmar. All these people are Sri Lankans who are working abroad, are at risk of developing malaria or bringing or reintroducing malaria to the country. Also pilgrims. This is all special risk category, pilgrims, especially to India, Myanmar, Thailand, and people who travel to African countries for safari. They are also at risk of malaria. So among the foreigners who are at risk, who work here in Sri Lanka, especially Indian and Chinese laborers working in construction sites, and tourists from African countries, asylum seekers, illegal migrants, especially entering from the northern province. They come in boats to Sri Lanka. And recently, a boat of Myanmar refugees came. So these are an Indian fishermen found in Sri Lankan waters, foreign students. These are the foreigners who can reintroduce malaria to the country. So you can see here, 89% of patients acquire the disease from African countries, and because of that, in African countries, Plasmodium falciparum is more prevalent. Because of that, majority of our cases, like 79% of our cases in 2024, were falciparum malaria, which gives more severe complications and deaths. So these are the countries' reported cases. You can see other than India, the Ethiopia, Kenya, Tanzania, Mozambique, Madagascar, Gabon, Nigeria, Ghana, Guinea. So all these countries are those are the African countries which all these people have gone to. So this is the country list. If you scan this QR code, you can get access to this list of countries which you have to think of malaria when you take the history. So to prevent severe complications and mortality, timely diagnosis is very important, which is in your hands. So this is the place we expect your maximum support to early identification of suspected malaria cases and confirm the diagnosis. So we think there is no indigenous transmission within the country. That is why we focus on risk groups, which I mentioned earlier. But we don't know whether there is ongoing transmission with the introduced cases. So we change our guideline to screen all patients come with fever, irrespective of their travel history. So please think of malaria and include in your differential diagnosis when patients are presented with fever. Try to discover the travel history, because these people are hiding the travel history in most of the time. So recent case, we observed that they do not divulge the travel history, especially when they travel illegally and also travel without knowing the Sri Lankan community, because that is common among gem traders that we observed. They have families in other countries as well, and they travel there for trading and to live with them without noticing of the Sri Lankan family and come back home. So then they do not reveal their travel history, don't say that they go to these African countries and came. So because of these, human relationships are complex. We thought, without taking a risk, screen them for malaria when they have fever. Like screening for acute flaccid paralysis to identify these polio patients, we will screen all the fever patients to identify either indigenously transmitted malaria cases or introduced cases or imported cases. It may be not practical to screen all, but our officers, especially public health field officers, or we have appointed public health laboratory technicians into these major hospitals, and they will come and collect random samples from your hospital, from fever patients, and I would like to request you to allow them to screen these fever patients in your wards. But in private practice, if your patients are known to you, try to find links to these risk groups or risk of exposure to malaria, and if indicated, please do a test for malaria parasite. So this first graph shows total delay in diagnosis. That means from the onset of symptoms to diagnosis. And the second graph shows the time the patient first came to contact with the healthcare facility to the time of diagnosis. So the secondary delay is also there, because our doctors, we miss the suspicion of malaria, and they do not test these patients for, do not order screening these patients for malaria. So this there is a diagnosis delay within the hospital, because we do not include that in the different diagnosis. Even the travel history is revealed, we forget to order a malaria parasite microscopy for these patients. So the main aim of this lecture today is to bridge this thinking gap and draw your attention to think of malaria and be vigilant when a patient is presented with fever and travel history. If there is a suspected patient, you can call our hotline. Anti-malaria campaign has a hotline. There is a slide with the hotline number. And also, we send you a SMS to your phone every 30th of the month and reminding you about malaria. So we have been scolded by some doctors in social media as well for sending this message every month, thinking that we don't, because why these AMC people does not have any other work to do, sending messages to all the doctors monthly. So, but we are on pins all the time, thinking there will be a miss in diagnosis somewhere in the country and give rise to a silent outbreak. That is why we remind you all the time, every month, that there is a disease called malaria. Think of malaria when there's a travel history. Be vigilant, and you have to have this in mind all the time and include it in the differential diagnosis. Also, if you want to find the hotline number, it is there in the SMS that we send you monthly. And if you inform us, we can arrange screening for your suspected patients. So in 2025, so far we have 18 cases. In the morning also today at 1 o'clock, again another case was reported. Now it is 19 cases. So 83% of these patients in 2025 were males and 83% were Sri Lankans, and 67% out of Sri Lankans were Sri Lankan working abroad, and 20% were pilgrims to India and Nepal. There was one gem businessman and one pilot from Air Force. Today morning case is also seaman who has traveled to African countries. So we have prevented 3 deaths so far in this year who developed severe complications. The first one is a returnee from Tanzania. The diagnosis, secondary diagnosis delay was 4 days, and he was found with more than 1 million parasitic count per 1 microliter of blood. He was, when it is presented in 𝗙𝗘𝗓𝗦𝗕𝗦𝗖𝗥𝗜𝗕𝗘, he has developed complications, and patient was treated and he recovered. And there was another case reported. He's a returnee from Sierra Leone to Jaffna. It's an illegal migrant. Actually, it's legally he has gone out of the country. He has gone to Sierra Leone with the promise of this travel agent that he will be sent to European country from there, but because they have not sent these patients as promised, they have returned back to the country, and he has not revealed the travel history. He's a 24-year-old boy, and the secondary delay of diagnosis was 10 days. And when he develops cerebral malaria, and when the GCS score dropped only, we got to know that this one was from a returnee from Sierra Leone, and he went to all these complications and went to DIC and pneumonia, but because he's young, he recovered from these complications. And last case also from foreigner from France. It's a 10-year-old she's a visitor to Bora Convention now happening in Colombo from 27th to 6th of July. There are 15,000 tourists have come and lodged in Colombo area and attending this Bora Convention. But this small girl, he's a 10-year-old, has traveled to Reunion Islands 1 month back, and she has acquired the disease from there. Parasitic count was low, but she was admitted with shock. She was, till yesterday, she was in the ICU in LRH. Today, she will be transferred to the ward, and she was also treated and recovered. So fortunately, local transmission has been interrupted because vulnerable populations shown in this orange color map, and the receptive areas where the vector is abundant do not significantly overlap within the country. We get majority of cases are reported from Western province, but we don't have vector to make it an outbreak. That is why we are still safe and still we have been able to prevent the transmission. But you can see the map. All the districts are at the risk of getting at least, see, this is from 2013 to 24. Less than 1 to 20 cases have been reported from all the other districts other than Western province. So this is the treatment of malaria. This is our treatment guideline. We can share this treatment guideline with you all. And these are the features of patients likely to have malaria. Any febrile or afebrile patient, even they do not now it's not like everything. You may have heard that malaria is occurring every 3 days with chills and rigors, and the fever goes off with excessive sweating. That is how we were taught when we were in the faculty. But there are now atypical presentations as well. Even if afebrile patients with symptoms and signs such as fatigue, joint pains, headache, myalgia, vomiting, they also has to be think of malaria if they have travel history, especially travel history to malaria endemic countries within past 1 year, belonging to high risk group, think of malaria, and with a history of malaria infection within past 3 years, or for in patients with pyrexia of unknown origin, think of malaria. And also if patients presented with clinical features suggestive of severe malaria like low GCS, drowsiness, convulsions, those kind of patients also think of malaria if they link to these high-risk groups. And any patient with multiple organ failures can be malaria, and anemia of unknown cause, it also can be malaria, and patients with hepatomegaly, splenomegaly, and the recipients of blood or blood products who develop fever within 3 months of transfusion, you have to include malaria in the differential diagnosis. So notification, you have to notify if there are suspected patients, and notification on malaria is important. It should be notified to epidemiological unit through H544 form from the hospital as well. You have to inform AMC headquarters or the RMOs. We have regional malaria officers in all the districts. So either you inform to the RMO or to anti-malaria campaign headquarters. This is our hotline. This is functioning 24 hours, 365 days. Our doctors are keeping this, and they are always answering all these calls and messages. So you can take a screenshot of this and keep this number safe, and it is also there in the SMS that we send you. Once it is notified to anti-malaria campaign, we can confirm the diagnosis, because all these diagnosis facilities are there all over the country. We have trained microscopists, public health laboratory technicians in especially teaching hospitals and some base hospitals, all these general hospitals, all these hospitals, main hospitals they have. And we have regional laboratories in regional malaria officers. So there are trained staff there, so we can confirm the diagnosis. And we provide anti-malarial drugs, because drugs are with the anti-malaria campaign. So that is how we get all the notifications. Anyone who diagnosed the malaria have to contact anti-malaria campaign to get the drugs. And we provide guidance on treatments. And we follow up the patients with repeated microscopy till the parasitemia is cleared. We do microscopy of the patient, and thereafter also we follow them up for 42 days for falciparum malaria and for 1 year for vivax malaria. And we initiate case investigations and do all the surveillance activities and response accordingly if the vectors are abundant in those areas. So malaria life cycle gives us a clue on how to calculate back the day the patient acquired the disease. So it can be from within the country they can acquire, or they can bring it from outside. So to calculate that, this is important. So falciparum hepatic cycle takes around 5 to 7 days. And the erythrocyte, because when these sporozoites are entered into our blood, they go to our liver. So in the liver cycle is the hepatic cycle. It takes about 5 to 7 days, and thereafter these chysons enter into RBCs, red blood cells, and this cycle takes 42 hours. That is why we develop fever. After each cycle, these red blood cells rupture, and they get fever with chills and rigors. So every third day they get fever. And to continue the transmission, they should have gametocytes in their blood. It takes about 10 to 12 days, and the mosquito cycles again take like 2 weeks, 10 to 14 days. So this is how we can locate from where this patient has got the disease. If the patient develops fever or other symptoms of malaria after 10 days of returning to the country, then there is possibility of them acquiring the disease from within the country. And the so that is how we calculate if the incubation periods, because this 7 days in the hepatic cycle and 3 days in, it's altogether 10 days. If they have developed symptoms within 10 days, then definitely it's not from the country, they have brought it from outside. So main symptoms are fever with chills and rigors, myalgia, arthralgia, headache, fatigue, nausea, vomiting, and especially thrombocytopenia. So they get thrombocytopenia. So malaria can easily be mixed with dengue. So nobody think of malaria when they have thrombocytopenia and fever. They always think for dengue and treat. This may be also mixed with seasonal viral infections as well. The malaria can be diagnosed either by microscopy, that is the cheapest method, and the facilities available island-wide, and or using rapid diagnostic tests. Currently, in the government sector, we don't have these RDTs, but the private sector has. So, if you want to get them screened for malaria, please inform us. We will arrange the screening for your patients. The main objective of treatment of these patients are to save the patient first and to prevent local transmission as well. So all these treatments are given after admitting the patient to a ward under the observation of visiting physician, VP care. We will administer all these drugs. The treatment differs based on the species. For Vivax, we give chloroquine and radical treatment with primaquine. Those are calculated according to body weight. This is how we give 10 milligram, 10 milligram and 5 milligram for 3 days. So we admit this patient and keep them in the ward at least for 3 days till we complete the treatment. Otherwise, we don't know whether if they discontinue the treatment on halfway, we are not sure whether they will give this to mosquitoes and continue the transmission and reintroduce the malaria to the country. Because of that, to make sure that they take the treatment, we admit the patient and treat them for 3 days. And primaquine for Vivax, because they have hypnozoites, we give them treatment for 7 days, and after testing for G6PD deficiency. And for the falciparum, we give artemisinin combined treatment. That is also for different body weights. There are different regimes, and we give a single dose of primaquine for these patients with falciparum malaria. And these are the ACT tablets. We get this Quantum brand, and there are different regimes for different patients, different weights of the patients. And for severe malaria, based on their parasitic count, Based on their parasitic count, we either give 1 dose of IV artesunate, or if the density is more than 200,000, we give 3 doses of artesunate, and based on their recovery, if they can take oral, then we change it to oral ACT for another 3 days, and we give single dose of primaquine. This is the summary of treatment schedules for different patients, either with monoinfection or mixed infection. For monoinfections, we give this chloroquine and primaquine. If they have uncomplicated mixed infection with falciparum vivax, again we combine this ACT and primaquine for 14 days. For severe diseases, we give IV artesunate, and or if it is not available, IV quinine. And patients infected with other parasites, again chloroquine and primaquine. So this is what we do in malaria campaign when a patient is reported. So we treat the patient, then we initiate parasitological surveillance within 24 hours. And we do contact tracing to find other people who travel with this particular patient. And also we trace similar risk groups in the districts, either through patient or through travel agents who send these patients to other countries. And also we initiate vector surveys to identify possible vectors for the transmission. And these are carried out in areas where patient had overnight stays with symptoms, and before that also. And if indicated, vector control is done either using insecticide residual spraying in the houses or using long-lasting insecticide impregnated bed nests. So we are ready with all these vector control methods and all these drugs, screening, diagnostic, everything is available, and only thing that you all have to suspect these patients and refer them to us or notify them to us for us to initiate all these preventive activities. Once the parasitemia is cleared, we follow up the patients for 1 year in the case of vivax malaria and falciparum malaria up to 42 days. So as I mentioned, all the suspect patients, microscopy should be this one. The microscopy, if you suspect malaria patients, and if the report come as negative, actually you have to do repeat this microscopy for 3 consecutive days for you to exclude malaria, because when the densities are low, it can be missed because it is seen through the microscopy, and all the PHLTs are not there is a chance of missing of these 1 or 2 parasites in the cells. So because of that, we ask you to request you to repeat this microscopy for 3 consecutive days when there is a suspected patient. So we can arrange that. Only thing you have to request. So the prevention of reintroduction is mainly done through mosquito bite prevention during their stay in malaria endemic countries, and providing chemoprophylaxis for the travelers going to endemic countries. So bite prevention is by avoiding outdoor activities from dusk to dawn when they are in other countries, malaria endemic countries, wearing protective clothing, using repellents, and sleeping under a bed net, as these Anopheles mosquitoes are night biters. So it's easily can be prevented by sleeping under bed nets. We give and chemoprophylaxis. We issue chemoprophylaxis for Sri Lankan travelers to malaria endemic countries, and it is only available at anti-malaria campaign. Not only the headquarters, all the regional malaria offices, we have kept this chemoprophylaxis, and we give chloroquine as prophylaxis for countries with vivax malaria, especially India, and mefloquine for African countries, and doxycycline if other chemoprophylaxis is contraindicated. So chloroquine and mefloquine is a weekly dose that we give, which has to be started 1 week before their travel, before departure, and continue during their stay in these malaria endemic countries, and continue another 4 weeks after they return to the country. So when you come across with these patients, your patients who are going abroad, please make them aware and ask them to collect their drugs and to use them to prevent them getting the disease. And also you have to tell them once they come back, they have to get themselves screened for malaria whenever they develop a fever within 1 year of arrival. So that also have to be communicated to your patients. So not only the patients, your relatives, or even if you are traveling, please note that these chemo prophylaxis are available. They are everywhere in the country. You can collect it from our RMOs, regional medical officers. And all the public health programs have their own challenges. So one of our main challenge is delay in diagnosis by doctors. So this delay will allow reintroduction of the parasites into the country, as the vector mosquitoes are abundant they are in normal numbers still in the country, and we don't know our coverage and compliance of chemo prophylaxis. We don't know how many people are going out of the country, or number of people who travel to these endemic countries. There is no way of us getting that information, and continuous importation is a challenge for us, and there is no way of capturing them at the airport. It is always voluntarily. They have to get themselves screening. We have a port health office, so they can go there if they have fever on arrival, or we have displayed our numbers there in the airport as well. It is a voluntary process, so we can't make it mandatory to get them screened at the airport. So the importation is a problem, especially people who are coming from these India and African nations. And the illegal travelers also another challenge that we cannot address. And climate change and environmental factors favor vector breeding. Still, we do not have observed any resistance to insecticides or drugs, but there are countries with resistant malaria, especially in Mekong region. So when the people who goes to these countries, they are at risk of having drug resistant malaria. So still we have not observed any in our country. So to prevent it, actually we use combined therapies like artemisinin combined therapy. That is why it is used as combination therapy to prevent this resistance. And we constantly monitor mosquito resistance for insecticides, as they should be susceptible for us to knock them down with insecticides in an outbreak. So and sustaining political will for an eliminated program is a most challenging task for us, and also ensuring rapid response capacity in case of reintroduction is also challenging, as we carry out continuous capacity building program for sustain their expertise within our staff. And we are ready to act upon any outbreak that might develop in future. And these are the key messages for clinicians. Malaria can recur in this country, and suspect malaria in patients with fever, especially with travel history. And dengue and malaria can present with same clinical features, so it can be missed. So think of malaria. If suspect, check for malaria parasite, order microscopy or RDT. And malaria cannot be excluded with a single negative result. 3 consecutive blood films should be performed, and notify suspected cases to our hotline or to RMO or MC headquarters, and admit the patients if they are positive to hospital with a VP. And appropriate treatment should be given according to national guidelines and follow up. And we have to ensure prophylaxis is provided to all travelers to malaria endemic countries before their departure. and check blood for malaria on their return. So these are the key messages for you. And for the general public, make them aware, and they should be aware of, you should make these communities, families, friends about this testing, the facilities that we have, preventive aspects and the blood donations. And they should know that it can be reintroduced with traveling to these countries, and we should ensure that prophylaxis is provided to all these travelers to endemic countries before departure. Actually, they have to start it 1 week before. And promote testing when the fever develops within 1 week, 1 year of arrival. And assist regional malaria officers and anti-malaria campaign to identify high-risk groups. If the MOHs are here in this forum listening, please support our RMOs to identify high-risk groups in your MOH region. If there may be frequent travelers, and there are communities like gem traders, so identify them and notify it to our regional medical officers. So they will do screening and follow them up and provide prophylaxis for these risk groups, and assist parasitological entomological surveys if they are conducted in your area as reactive response to all these positive cases, and assist in vector control, because in some provinces they don't allow us to introduce fish into these wells, especially because they are using those wells for drinking purposes. Sometimes they don't allow us to introduce fish for the water bodies with these larval stages. So you all can support us, especially the MOHs. And these are the banners that we develop to display in OPDs, and you may have seen this in your hospitals. We have displayed our hotline number there, and the country list is there in the poster that developed for specially for the OPD doctors. If your patient has this travel history, think of malaria. And for the blood banks, we develop another one with the country list, and every drop should be free of malaria. So we have to defer donors who have traveled to malaria endemic countries within past 3 years if you all are working in blood banks. And this is for the patients who are coming to our clinics. And we also have developed this leaflet to place in the back seat pocket in Sri Lankan Airlines. So we have not still implemented it. So that is all for malaria. If you all have any questions, you can ask from us. So thank you for your attention and listening. I don't know whether you listen. So
we have a question, madam, actually. Is there any screening happening for all African travelers at the airport when they come back?
No. That is why I said it is difficult for us to make it mandatory. Actually, we get from Border Risk Assessment Center, we get an email 2 hours before they are landing. These are the people who are coming in the flight from African, because all these African flights, we get notification, but we can't make it mandatory for them to get themselves screened. It is a voluntary screening. What our main aim is, because of that, we have displayed all our information in the airport and place it in that in the corridor where they go for all these gates. From there onwards, it's only voluntary testing can be done. They have to present to us. We are in the process of having a discussion with these airport authorities to actually before they stamp this stamp their passports at the immigration, for them to at least to refer to a desk where we can get them screened or make them aware to get themselves screened when they develop fever. So we are working on it. Still, there is no such thing. It is not. We can't make it mandatory according to the international health regulations, IHR.
So, madam, can I have a question?
Yeah,
as
yeah, sure,
well?
sure.
Is there any vaccine that globally
Yes.
under development to prevent this
Yes,
malaria?
there is a vaccine, but it is not, we can't get it. It is given for countries, especially African countries, and it is tested for to give to small children. Now, they have piloted it and they are implementing it for small children, but it is not indicated for the people who are traveling abroad or anything. Still, it is not available for adults. So there is a vaccine, but we cannot get it because we are eliminated anyway. We will not get any vaccine for our country.
Thank you. So, as medical officers, we have so much responsibility.
Yes,
since
of
there
course.
are 19 cases recently reported to give the message to our public. Actually,
Yeah, actually, this is a good opportunity. Thank you for the GMOA for giving us this opportunity to address all the doctors in the country, because it is all our responsibility of all of us as doctors to prevent reintroduction of malaria to the country. So,
thank you, madam. It's a very interesting lecture. Before we are ending the lecture, we will let us again remind that hotline actually 071284177 when there are any inquiries or to inform about the malarial disease. So we will contact through that.
yes, thank you very much.
Thank you so much.